Good evening, everybody, and welcome to another episode of Fertility Talk. It's 8 o'clock. We're doing it on a Thursday evening. Just to let you guys know, I am currently experiencing load shedding, so I'm trying to make everything work. But I wasn't going to postpone this talk. It's the first time we've got Dr. Geyser here. And Dr. Geyser is from the Femme Fertility Clinic, and that is out in Northwest Rustenburg. So if any of you guys are in that area and this is the doctor to go and see with regards to any infertility issues that you might have. So we've got a good topic today. It's unexplained infertility. Or unexplained fertility. And this is what we're going to discuss with Dr. Geyser. If you have any questions, please put it in the comment section of Facebook or at the end of the talk. What I'll do is I will leave, Dr. Geyser will give his details, and you can then contact him directly at the Femme Fertility Clinic. So thank you, Dr. Geyser, for joining us today. Really appreciate it.
Leanne, thank you very much, and thank you for the opportunity. It's appreciated.
Great stuff.
Thank you very much.
Thank you. Dr. Geyser, please give us, first, before we start, please give us a little background of what did you do, what made you decide to be a fertility specialist, and where is your fertility clinic?
I work in Rustenburg. The hospital that I'm based is Life Regular Hospital, and then the clinic that I have is the La Femme Fertility Clinic. We opened this clinic just before COVID started, so that definitely had an impact on our business. But I think things look like they're starting to return to normal, and I'm sure we are going up from there. So yeah, looking forward to that.
Absolutely. Sorry, you can continue.
No, I think in the Northwest, there is other clinics, but I think I'm probably the only registered specialist in the Northwest, as far as I'm aware. So we use our clinic to have our consultation rooms at the medical suite in Pegler, and then we use our clinic there at the La Femme Clinic to do our cut and our fertility work.
Okay, awesome. Okay, then our topic today, we said, is the unexplained fertility or unexplained infertility. And we have a few questions for you. First of all, what is unexplained infertility, or what is unexplained infertility?
Yeah, so basically, if we talk about unexplained fertility, we talk about what infertility is to start off with, and I think everybody is quite aware that you have to try and conceive at least for 12 months unsuccessfully, and if a patient is older than 5, then we would usually shorten that period to 6 months. Due to climate running out, basically. So approximately 7% of couples will struggle with fertility-related problems, and about 15% of patients would consult the doctor for fertility-related problems. So basically, absence of a definable cause, or after we've looked at everything that we know, and we don't find anything, everything is normal, then we would classify these patients as having unexplained infertility. I think it's also important to know that the World Health Organization has defined infertility as a disease. So it causes significant morbidity in patients, and it's a major distressor, really. So and it should be assessed thoroughly, and you should take every precaution to try and find out if there's a cause. And then the counselling, of course, is important for these patients.
Yeah. Okay. The next question. Sorry, have you finished that? Sorry.
I don't know if there's anything specific you want to. I think in the next think there will be questions. We talk about what causes are and how to exclude those. But I think basically unexplained, everything that we know about is normal. We've done everything, and everything is normal, but it's not happening. So I think that's a major frustration for people, and I think for doctors as well. If you know there's something you can treat, it's always nice. So, yeah.
Absolutely. How does one get diagnosed with unexplained infertility? So how do we get to that point?
So if we look at the factors that are involved, it takes two to tango. So, and people tend to think often males are generally of the opinion, lots of them, that the problem must be with the female, which is definitely not true. But if we start looking at, we as gynecologists usually see our female patients first. So if we look at the causes after, it would usually be most of those would be of ovulation. So it has to do with the regularity of the cycle and so on. The ovulation problems, and then, well, attached to that would also be the ovarian reserve, which would be the eggs and the capability of the eggs to make it enable a woman to conceive. And then we look at tubal patency and the uterus itself, the cavity of the uterus. So that is the thing that we would exclude in the female as a cause. And then also the male semen analysis is important. And if that is normal and there's no other out of history, there's no other sexual dysfunction, nothing else that explain that, then we would classify these patients as unexplained infertility. And there's no specific biomarkers that we have to make this diagnosis. So, and we know that if we look at these patients, they usually have a reduced capacity. Well, if you look at patients with what we call infertile, it means that they have a reduced capacity to conceive compared to the mean capacity in the general population. And I think it's also important to explain to patients when they come to you, they know that what is the chances of getting pregnant per cycle. So, and normally one would expect that about 20% of patients normally that doesn't have problems will be able to get pregnant per cycle on their own. And we would expect about 60% to be pregnant in 6 months and 80% in 12 months. And if it doesn't happen, then we would start looking at these patients. So, and yeah, I think that answers that question for you. So.
Okay, thank you. Okay, the next question we have is it possible to conceive with unexplained infertility?
I think, infertility doesn't mean that you are not able to get pregnant. So, and if we are expectant in these patients, we do nothing for them. We know that 1 to 3% of these couples will become pregnant each month. And there's also, if we look at those patients that have a good prognosis to get pregnant on their own, it would be your younger patients, those with no bilateral or tubal diseases and no sperm related problems.
Yeah.
And patients that are less than 32 years of age and have a normal ovarian reserve, they have a good chance of getting pregnant on their own, as opposed to the older patients, about 37, they have less than 1% chance to get pregnant per cycle on their own.
Yeah. Okay. So the next
with that unexplained infertility, if we look at IVF, for instance, we would normally find that we look at normal live birth, and in patients that are younger than 35, we would expect about 45% pregnant with IVF, and then as the age progresses, it gets less.
Yes.
So.
Okay. Sorry, doctor. There is quite a delay, and so it's not I'm trying to make sure I'm hearing everything you say, but I think there's just a serious delay at the moment, and I think it's due to my load shedding. Please, how common is unexplained secondary infertility? Yeah, how common is it when it's, when you'd always expect when someone says, I've had a baby, and now all of a sudden, how is it that I can't conceive, in the secondary infertility? Yeah, how common is this?
Well, according to the statistics of the World Health Organization, it's about 15% of you've done everything that you would not be able to explain. And we know that, well, obviously there should be a cause, but there's things that we are not always able to measure accurately, and that would include things like implantation problems. So they get pregnant, but the fetus is not, or the pregnancy is not, the embryo is not able to attach to the uterus, or there might be subtle problems with the cervix itself, or problems with the sperm and egg transport, even the interaction. And there's other things like immunological factors and adhesions in the uterus.
Yeah.
So, yeah. And we know also that if we look at these patients and we do IVF on them, they have a reduced chance to, also the oocyte fertilization rate is lower, there's a higher rate of fertilization failure, and also probably underlying functional abnormalities in the other sites of sperm function.
Okay, perfect. And then let me just get to our next question, Doctor. You still okay there?
I'm perfect, yeah, thank you.
Okay, great. It's just the first time, so I want you to be very at ease, so we can have you back again, Doctor. Okay. How does endometriosis factor into unexplained infertility? And this month is Endometriosis Awareness Month, so it's best that we actually discuss this. Endometriosis factor into unexplained infertility.
I think endometriosis is, I think people are very aware of endometriosis. We see it frequently, definitely an issue. But globally, the whole spectrum of what causes infertility and what the chances are. So most of the problems would be ovulation disorders, which makes up about 20% of female problems. Tubal disease, especially in Africa, it's about 14%, as opposed to endometriosis would be about 8%, which is actually lower, but definitely if endometriosis is found and it's treated, and we treat it surgically by preferably excision of or visible endometriosis, then that's definitely associated with improved fertility rates. Okay. And even superficial endometriosis definitely has an influence. So, yes. So endometriosis is an issue. So often, these patients present with pain, and that's patients that we normally see. Patients will first come and they have a painful menstruation. But if we talk specifically about unexplained infertility, it means that these women are asymptomatic. They don't have a problem. So, and we might end up evaluating some of these patients eventually, if we don't find anything else, as part of the workup, because we know sometimes endometriosis might be asymptomatic, but doesn't mean it's there. We see that as well. And then, so that's by exclusion of all.
Wow. Okay, and how does the age of a woman factor into unexplained infertility?
I think female age is probably the fertility specialists' biggest challenge. As a lot of these patients that we see, they come to you, they are 40, 42, never been pregnant, and you would be amazed how many places they've been. They've seen the primary health physicians over the years, and there wasn't even a semen analysis done. And they come at these states. So after 37 years of age, women's fertility rapidly declines due to a decrease in the functional egg pool, if you can put it like that, and also the quality of the eggs also declines. So yeah, and if you look at the percentage of couples that we see with that struggles with fertility-related issues, about this 1 out of 7 couples in the younger age group, less than 35, would have problems, and that will go up to 1 in 5 couples between 35 and 40, and at least a quarter over 40. And by the time they get to 45, the chance to get pregnant with IVF is virtually 0. So there's definitely a timeline, and from 37 onwards, it's an issue. And then you will have to, and if you look at older women that don't have eggs, the only option with donor eggs. So, and for those women, you might restore their chances of fertility back to normal if they don't have any other problems.
Okay.
So donor eggs is a thing for the older women. There's still possibility to get pregnant.
Yeah. Because I actually got an email yesterday from someone. Unfortunately, she's 49 years old. And it was a very difficult conversation to have. And I sent her, I gave her doctor's details, or I sent her details to one of the doctors, fertility specialists in her area. And just for that woman, for that lady, what is her chances? Obviously, if she uses donor eggs, because this is something that we obviously would get asked at time, like I'm 48, I'm 49. If she's using donor eggs, is there still a chance for that patient?
No, definitely, absolutely. So, if we all know about these, miracle cases of 60, 70 years old, had a baby, so which is obviously not something we want to do. But if your uterus is normal, and you don't have any other medical issues, then it's all about the age of egg. Of course, we have a cut-off point beyond where we would say, no, this is not a good idea to get pregnant anymore because, other factors, medical conditions, and child that has to grow up on its own and so on. So you have a cut-off point to say, no, beyond this, you should really not get pregnant.
Okay. How do you treat patients with unexplained infertility?
Well, I think the first thing how we would approach these patients is to do then a systematic evaluation of all the factors that that are involved. And then also along with that, we will look at their ovarian reserve markers, about age, and some people have operated maybe for endometriosis and often been damaged their ovaries if there was cysts removed and so on. So one has to look at that for the factors into that. And then a detailed discussion should be held with these couples to explain to them what is the best what is the options and what is the way forward.
Yeah.
So, and then I think in terms of management of these patients, we usually start with the simple things, so that consumes few resources, and the more patient directed, like lifestyle and time intercourse, make sure about ovulation. Lots of these patients you will sort out just by sorting out that, because they don't. People are not always aware of exactly what is the best time of intercourse, and make sure that they ovulate. So once you've done these things, we talk about the home plan that we send them for 4 to 6 months, depending on the age and so on. Then you'll sort out a lot of these patients before you have to go to any medical treatment. So if we don't succeed, then the next thing would be then to go on to things like ovulation induction that we'll do with oral medication, a combination of oral medication and which would be anti-estrogens or aromatase inhibitors, together with intrauterine insemination. And finally, if this don't work, we will go to IVF, which would be your final step. So usually our approach would be to do 3 or 4 cycles with insemination, and then the whole idea is with these tablets, that these 2 oral medication, is to cause mild ovarian stimulation. So ideally get to an extra. So in a normal cycle, we'll only have 1 egg at the time that gets released, but this will put it up to maybe double ovulation. That will increase the chances of falling pregnant, and also placing a large amount of sperm high in the reproductive tract. So would also, the idea is that would enhance their chances to get pregnant. So what we basically use is 2 drugs, tamoxifen, citrate, and letrozole. Letrozole is not really, it's actually off-label, but there's studies to show that it's really not inferior, and in fact better than tamoxifen in certain circumstances. Although it's more expensive, so we might have to look from that point of view. And if they don't conceive, then we'll go on IVF as our next step. We have a much higher pregnancy rate per cycle and at the shortest time. So the older patients might move faster in that direction. So after 40, not so much a good idea now start with oral medication. One should really consider going more to IVF in that specific.
Awesome. Okay. And then there's a last question we have. We've got quite a few IMs, guys. I'm seeing all the comments here, people saying that they are struggling, no help. Guys, what I will do is, okay, so one question is, I'm 38 and I'm in Fertility Clinic, and I was told it's Unexplained Infertility and IVF is our best chance, but IVF is so expensive. What else can we try besides IVF? And I think, Sunette, in this case, if your fertility specialist, I don't know, doctor, if you want to answer Sunette here. She's saying that she's 38 years old already, and the doctor is recommending IVF. Would you also recommend IVF?
Well, I think there was a good study done in patients that are 38 and older versus with unexplained infertility, where they did half of the patients that did IVF, and the other half of the patients did insemination first. So most of the patients that are pregnant with IVF. And much shorter interval. So time is of the essence. I think ovarian reserve depends on a specific medical condition. Whether ovarian reserve is an issue, if it's normal, there's no other problems, then definitely insemination is an option, because it's much cheaper and it still have a chance. So generally, if you look at that data, it will tell you that for 4 cycles of insemination, it is equal to 1 cycle of IVF, which is around 40%. So just to put that in perspective, and insemination can definitely work. I think one has to caution maybe in this regard. I didn't mention now the gonadotropins, that is injections that we use to cause hyperstimulation in IVF, so you can get multiple follicles. So there is a specific subset of patients where we would use the injections. Either they don't, react to the tablets because they've got resistant PCOS, or they simply can't afford IVF. So then in that specific subset, gonadotropins has a higher success rate, although it's just marginally up. But one has to caution about multiple pregnancies, because that is definitely your risk, and then cost is an issue for those patients.
Okay.
So maybe I wandered off a little bit, but I think in those specific circumstances, that is the thing that they would have to take in consideration. But IVF would have the best. The quicker would be the best chance and the shortest duration. Yes.
Awesome. Yes, and because there's an age factor, so it would be the better option. Okay, we have someone that's looking from Nigeria. If you can come down to South Africa, you can see Dr. Geyser. And then we've got someone struggling with, Dr. Geyser, give me someone with PCOS is struggling with falling to conceive. Yeah, so Marius, what you can do is you can actually, I will give Dr. Geyser's details at the end. Dr. Geyser will leave his details, and then you can actually email him, or maybe you just want to say something about that, Dr. Geyser?
Was it PCOS?
Yeah, someone struggling with PCOS trying to conceive.
I think PCOS is probably, I think, the easiest patients to get pregnant. And we see lots of those patients. But again, going back to lifestyle, because a lot of these patients, about 80% of them, have weight-related problems. And then we subdivide patients between, the skinny patients, the more overweight patients, the patients with insulin resistance, other metabolic factors, cholesterol, glucose, so there's a lot of things, and thyroids that we have to exclude. And after we've excluded all these, then we will look at the specific patient and say, well, diet is going to be something that they have to work on. It's not an absolute that they have to lose weight before you get pregnant, because that's a whole discussion on its own. But definitely that will help. They will benefit in terms of getting pregnant easier, this medication, and have a healthier pregnancy. So, but once you get on that point, ovulation induction, and usually with tablets, clomiphene citrate or letrozole actually work better than that group. And often also glucophage, which is the used for diabetic patients who use that. That has to do with the insulin resistance. So, but that is the patients that they're usually younger, and it's easier to get them pregnant. So, yeah, so definitely there's hope.
Awesome. Okay, so our lady from Nigeria is please asking for your email address. Dr. Geyser, do you mind please giving all your details if anyone wants to get hold of you, contact you further?
Hey, what I will do, I will share it with you. I'll just see if I can share this screen with you.
And let me just see, I have to multiple, there we go. I've just given you option to share. Kelechi, I'm seeing, I hope I'm pronouncing your name properly. What I will do is I will also post it in the comment section there. And there's Dr. Geyser's email address is dr.pieta@mweb.co.za. And the website is www.pietergeyser.co.za. It's the Femme Fertility Clinic in Rustenburg, but you can also find his details. That's great. You can actually find his details on our website, fertilitysolutions.co.za. If you look in the Northwest category, you will find all Dr. Geyser's details. And if you check any of our social media pages, Dr. Geyser's details will all be there, email addresses, and you can contact him in the contact form, or even just email me info@fertilitysolutions.co.za, and I will send your details off to Dr. Geyser. Dr. Geyser, thank you so much. And Sunet's saying thank you very much for your answer. For IVF, I think she's feeling a bit more at ease and knowing that she's doing the right thing, making the right decision also to go ahead with the IVF. So we wish you all the best, Sunet. Let's hope it's a big fat positive for you. But Dr. Geyser, thank you so much for your time this evening. We really, really appreciate it. It was quite a good topic to discuss.
Thank you for having me.
It's a pleasure. And we had quite a few listeners and people sending messages and likes and loving your talk. So thank you, Doctor. Have a great evening further.
Thank you.
Bye.